And today we have a very illustrious speaker in Dr. J.K.Reddy from Coimbatore. And the topic today is microkeratome. The other speaker is from our center, Dr. Jyothi, who is our consultant for a long time. So microkeratomes has been quite a mainstay in our practice in Bangalore. I would say maybe half the cases we do are microkeratome based. So in that we have evolved techniques to take thinner and thinner flaps, and we have been giving consistently good results for the past 20 years. So I invite Deepthi to take over and start the proceedings. Thank you.
Thank you, Dr. Somnath. So I take this opportunity to invite Dr. J.K.Reddy, sir. It will be a privilege to have you and a hearty welcome to the episode 8 of Plan One. So, sir does not require any introduction, but I'll have to do it. Dr. J.K.Reddy is the Chief of Cornea at Shankara Eye Center and the Director of Technical team. And all his numbers go into lakhs, so that shows his experience and surgical skills. So he has more than 1 lakh ocular surgeries to his credit. And he has always been fond in teaching and sharing knowledge. So he's a true teacher. He has presented more than 1,000 talks, more than 20 publications, and has been a postgraduate and DNB guide for more than 20 years. So, and a huge list of accomplishments. So how we know Dr. J.K.Reddy is, I think he's a go-to person when you need to think out of the box, a true thinker, a true innovator. So when we were thinking about the microkeratome talk, we had a lot of thoughts. So with the surge of the surface ablations, with the talks on the femto and the smile, I think microkeratome has its very major space. And due to a lot of things maybe commercialized or things, it's not very well portrayed these days on the platforms. But coming to the true reality, I think majority of the, other than the bigger institutes who can have smiles and femtos who are slightly reduced in microkeratome, but I think majority of the refractive surgeon, as Dr. Somnath rightly said, have more than 50% of microkeratome. And compared to surface ablation, it's a little unpredictable when it comes to the mechanics. So we were thinking who best, and we could think of no one other than Dr. J.K.Reddy. I think he has used every possible microkeratome, probably from the make to the time it has been abandoned from the market. And he's a person who really goes into technicality, maybe a microkeratome or even a LASIK machine. He has a lot of innovative works in building machinery. So I think this very important topic, which it's a little tricky. It is very important, and I think if you have a complications in microkeratome, it's not as forgiving as even a femto or a surface ablation. So I think you are the best person to deal with this, and also tell us where does a microkeratome stand in today, and give all of us a lot of tips, out of the box tips which you have innovated throughout the decades. And a true hearty welcome, sir. It's a true honor to have you here. So the whole stage is yours, and there's no time limit, so you can go on and on and on.
Thank you, Dr. Deepthi and Jyothi LASIK Center for inviting me for this very nice way of promoting or sharing information. More than promoting, we are not promoting any particular technique or anything. We share this forum. I think this platform will share more information of refractive surgery. So if you take, because she said no time limit, no, so whatever I'll be sharing with the industry people, if you take refractive surgery, people think everybody makes money in refractive surgery. That's not true. What we found around the world is if 100 surgeons, refractive surgeons, takes refractive surgery as a practice, or to make money, or to as a add-on practice, or out of interest or anything, what we found, really there are only 5 to 10% of the people who made big money, real good money. Remaining just as a routine practice because they have interest, and up to 40 to 30% not even 30, 40 to 50% people lost money in refractive surgery, the doctors. It's the same with the industry also. Most of the industry, the first one who started the excimer laser, uh, all the companies disappeared. There is nobody, all are bankrupt and they closed. Only few companies are staying back, which are very young, like Schwinn. Schwinn is a quite old company, 20, 30 years. But there are companies like Meditech, which is much older than Schwinn, which Jais, ultimately they closed down and merged with Jais. Uh, uh, Even V6 now, they stopped manufacturing, one of the leading companies. And Bosch and Lamb, almost Jayoptics number one uh, in India in late 90s and early 20s is no more selling, not even one machine per year. And Nidec, such a wonderful machine, number two installation across the world, now disappeared, almost no sales. And Laser Sight, the first company which started a flying spot laser, it's no more. It's bankrupt almost 20 years back. So the microkeratomes, SCMD, one of the best microkeratomes ever made. There's no company is not there now existing. Flop maker, nowhere. And Jayoptics XP, no microkeratome. They closed. The best microkeratome ever made in the Jayoptics and Handstone. Handstone and Handstone XP, no, they closed their business. So like that, it's not it's a very tricky business, the refractive surgery one. And coming to the microkeratome, it's the oldest one, and there are very few people who are surviving. Take some 2000 when we started our refractive surgery, there are so many companies making microkeratomes. There are at least 30, 20, 30 list of companies, and which one to choose is a big puzzle. Which one, this one, that one. Now there are no. You have only one or two making microkeratome. You have no choice. You cannot bargain. Whatever they say, you have to pay. So, so completely, it is a very tricky business. I don't say it's non-competitive. It's becoming very tricky. Uh, and small, for example, intraocular lenses. Many Indian companies are able to make. Even tomorrow, Alcon and Johnson Johnson closed down their offices because Alcon is for the past 3 years, 4 years, they're in terrible losses. They're just pulling off. Uh, there is no problem. We have Indian companies supporting us and many other companies, but not refractive surgery. There is no Indian company making microkeratome. Uh, so I start my talk in between any questions or uh, we can discuss in leisure, maybe around 20, 30 minutes. I don't go much into complications because all those complications are seen with the old generation microkeratomes now, no more seen and well properly maintained. I just go to the concepts of microkeratome and how we can best use this in our clinical practice. This is the basic drawing, maybe 100, 110 years old by Barakat. First, when Barakat made a first drawing, how a microkeratome, after a lot of hundreds of drawings. This is the one. Uh, the, the basic principles of what he drawn has never changed. The blade angle is supposed to be somewhere between 16 to 20 degrees, the angle which it cuts the cornea. There are many people, many surgeons and companies, they try to make it 0 degrees and 45 degrees, nothing worked. What original Baraka drawn 16 to 20 degrees in between. So the most sweetest spot is around 18 to 17 degrees. That is the angle at which it cuts the cornea. And opponent in the cornea flat. That's the same. It's remaining for more than 100 years. But Baraka doesn't make this microkeratome for laser. There is no laser at that time. Not even argon laser when he made this microkeratome. He made a microkeratome to cut the cornea, a thick layer of cornea, and take that. This is what the angle I'm saying. This is his basic microkeratome head drawing. Is the same thing still, and these lenticules, corneal lenticules, which were cut, are placed in a cryolathe, and they are used watchmaking industry. lathes to cut the diameter, to change the radius of curvature of the, cut the lenticules and reimplant and correct the refractive error, the spherical power. That's what he worked for more than 20 years. So once it's not very successful, the microkeratome gone out of, uh, somewhere the drawings are there in his library and in his warehouse, and the refractive surgery moved towards the radial keratotomy by Fidro. So then coming back after laser, and they need a microkeratome, then they took his drawings and started making microkeratomes. This is the cryolith, how they used to do it. I saw this incidentally in Saroj Devi Hospital in Hyderabad. There was a cryolith of Barakat. When I'm doing my post-graduation, I saw that they're not using, just they kept it as a ablation piece. So coming to the microkeratome, we have three parts in the microkeratome. One is the head, which I have shown the original Barakat drawing, a little bit alteration. Then a motor. The motor can be electric or it can be turbine. Initially, it is all nitrogen turbine. Then, like in dental bursts, the nitrogen passes, the gas passes, and the motor rotates. It's the simplest one. It's the best working one. It's the least troublesome one among all motors so far made in the world. It will never stop. It will always function. And unlike the electric motors which we are using, which are always prone for when they work, when they stop, God knows. It is not like that. It's always works. And this is the one, but completely went out of favor because of uh, it's a bit cumbersome, and but it is the best among all ever made, a motor to run the blade. And coming back, there is a to immobilize the eye, and for applanation, we have to use a suction. This is the suction ring, which both immobilizes the eye, and this is the it raises the intraocular pressure, so the head applanates the cornea for cutting the microkeratome. So these are the one. These are the assembled. These are three components. Is there right from the beginning for 100 years. They are not changed. They are a little bit moved this way or that way, but these are the three components of the microkeratome. This is the initial one. This is the turbine motor and connected to the blade, and this is the dovetail. In the dovetail, the motor only oscillates the blade. There is a sweet spot for the blade, that is 10,000 rpm. So 15,000 rpm cuts very smooth bed, but it produces a heat. So 10,000 rpm cuts very nice cut, but again they found this produces little bit heat. So now most of the people settle down between 7,500 to 8,000 rpm is the blade speed. Uh, all the companies settle down with that. So this is the RPM of the blade. So the forward movement is it's variable. Most of the times we go at a speed of 1 millimeters per second. Some will go a little faster, some will go a little slower. Most of the microkeratomes they give an option whether you want to go fast or you want to go for standard speed. But initial microkeratomes, there is no forward movement automated. You have to push with your hand. So I saw my cousin, Dr. K.P. Reddy, initially when he started his LASIK center in 1995, 96. He used to manually do it. Uh, Only the blade oscillation is by nitrogen gas. He used to use a CMD microkeratome. So manually he used to push. You have to trace the microscope. Whatever the flap hinge comes, you have to stop it. If you just pass, you will have a free cap. It looks very scary, but he used to consistently get very good results. He used to have a small line here. When this one reaches that line, he made it with a blade, so he used to stop it. So then he used to get a nice hinge. Uh, so they still say they used to get very good flop with that. Very economical. Each blade cost just less than $1. He used to buy blades in hundreds. So no question of reusing the blade. Every case new blade because just it costs 40-50 rupees each blade. So this is the first very successful microkeratom ever used as CMD. This is the nitrogen gas. You connect nitrogen gas and you adjust the pressures. Depending upon the pressure, the speed of the number of oscillations of the blade will be decided. The suction will be decided by the other pressure. So it's very strong suction. You never lose suction with this microkeratome. And if whatever patient does, the eye, you will never lose suction unless there is a problem with the tubing. So this is the one I told you, the turbine one, and this is completely autoclavable. You don't need to do like alcohol wiping or anything like that. You just remove it, clean it, and autoclave it. Completely sterile one. Only thing is they are little bit bulky and heavy when compared with the wires which we are using nowadays. And still it is in practice. It is not in practice for making flops. It is in practice for making a DSEC. Of course, with DMEC, the DSEC is also slowly disappearing. For DSEC, still the companies are making this microkeratome with a turbine microkeratome, which you can completely autoclave and use it. And then coming to the forward movement, when there is a lot of problems with the forward movement for different surgeons, as it's a very skill game, the, they started adding the gears to the blade. So along with moving the blade, the turbine motor also moves the gears. Those gears will move on a dovetail. Actually, this is not a dovetail. This is a rack and pinion mechanism, and there is a stopper for stopping the flop. This stopper is adjustable. The blade depth is also adjustable by putting a spacers. And then came the best and the most popular, which made the LASIK very popular, the handstone. The handstone was made by Mr. Hans and his wife and Dr. Burato. He emphasized that he got a great idea that flop should not be nasal, flop better to be superior, so it gives better stability for the flop instead of putting nasal. So he gave that as a challenge to Hans, and Mr. Hans made this microkeratome where he put a it's very genius making. Uh, there is a single powerful motor. It oscillates the blade around 6,000 to 7,000 RPM. Same mechanism is utilized by a eccentric pin uh, with a cross grooves, which will make the microkeratome move in a pivotal fashion and makes a superior flop, superior hinge flop. The superior hinge supposed to be the lead movement is supposed to keep the flap uh, very safe from dislocation. That is the basic concept. The only drawback with the uh, pivotal uh, microkeratomes, which make a superior hinge, is they don't make a uniform flop. They make a little trapezoidal thickness. So you cannot make you cannot make very thin flops with that. You have to make a little bit thick flops. But of course, at that time, there is no concept of LASIK ectasia, LASIK induced ectasia. It is not there. So they didn't bother. They made a 160 microns, 180 microns heads. For example, this head you can see it's 180 micron head. And this is the number of flops and utilized almost 90% of the world. And you have to wait. You have to pay the money and wait for a year, 2 years to just get this microkeratome into your hand. That is the demand at that time when it was introduced in the market. So the mechanism of forward movement is automated. Here also it automated. So the surgical skills have come down dramatically with this from sliding the microkeratome manually. So now even this uh, rack pinion mechanism was removed. The near microkeratomes has no, it's only dovetail, it slides. So there is no obstruction. If something goes here, a drape or speculum, it will stop. So those spots are now with the near microkeratomes eliminated. They are all internally kept inside the motor system so that you don't have it looks very nice and very smooth and you can make very fine thin cuts. So this is the new one, the Moria microkeratome. You have this is the suction ring, and this is the mechanism through which it moves forward. The screw, basically a screw. You have two motors here, one motor here inside and one motor here inside sealed unit. This motor oscillates the blade and this motor makes the microkeratome or the head of the microkeratome to move forward and backward. So the Moria has got another one adjustment, this adjustable hinge, where this is a, you can make a 7.5, 8 or 8.5 for each ring size. This is a supposed to be one of the advanced features of Morio, but at the same time it is a sin. uh, Sometimes you just by mistake or sometimes whatever reasons, if you put a wrong, if you can't see properly, put a wrong value, you get a free cap. So this is the main problem with the Moria, and this is advantage, and this is a sin of Moria. And the heads all became very nice now. They are disposable. They are made with polycarbonate, and each case are two eyes. You can dispose them off. So there is no problem of cleaning and maintenance,
इन लोगों को मैं जगह बता देता हूँ
sterilization. All those problems of the head are eliminated.
इंडस्ट्री हाउस के बगल में एक बल्टी
And the Moria, which is still standing now, Moria is the one company which is standing, still making, remaining all very reputed company also stopped manufacturing Microkeratome. This control unit, uh, they are still, you can run a turbine, you can run SBK, latest one, or any microkeratome made by Moria so far in their entire history for the past 30 years. You can use one console to use all those microkeratomes. Whatever you like it, you can buy and you can use it. This is the big advantage of the Moria microkeratome. Then comes another company, which is these two are staying in the world now. Medlogics, this is an American-based company. Ross is the CEO, owner, all in one. He used to repair microkeratomes, so he started making microkeratomes 20, 30, 20 years back, and he's still sticking on. This is beautiful. This is what I am using. It's got also two motors, and the same one motor oscillates the blade, say 8,500 RPM. The other one forwards. Here he made it completely uh, automated and completely adjustment free. So the surgeon has no adjustments of hinge width, hinge length, anything like that. You just put the vacuum and you cut it. It moves forwards. Once it stops, it automatically comes backwards. So he made it very friendly, and for newer surgeons, it's very nice. And he gave a vacuum adjustment also. For example, places with low atmospheric pressure, like in Andhra, in Nellore, or Chennai, you don't need high vacuum. But in places like not exactly Bangalore, Bangalore is also a little bit high altitude. Places like Ooty or Dehradun, where you go high altitudes, you need to use more vacuum. Otherwise, the amount of vacuum is created from the atmospheric pressure. As the atmospheric pressure itself is low there, these non-adjustable vacuum microkeratomes, they put less vacuum, they create less vacuum. So the chance of suction loss is very high in those. So in high altitude, very rare. India there are not many places, but US it's very common high altitude places. We have very few places where there is a good clinical practice like Dehradun, very few. So those areas also you can adjust the vacuum, and you can have uh, trouble-free operation. And another advantage with this ML7 is he gives a calibrated blades. So you buy one head, 100 microns. You can use 110, you can cut 120, you can cut 90. So the blade is given as 0, 10, plus 10, plus 20, plus 30, like minus 10, minus 20. If you want to cut 90 microns flop, you can use minus 10. If you want to cut 110 flop with the same head, you can use plus 10 blade. That is a great advantage. You don't need to keep on buying more heads. That's a great advantage with this particular system. And this is the Moria one. Why I want to show this is whatever maybe, this part only changes. This dovetail is the same and the suction is the same. You may give some angle, all the things. What I found, one of the biggest problem, what I learned in my practice is the suction, uh, the automatic, the machine initially gives an option of checking the suction, where the suction is checked. So what we pinch the tubing here, then you press the button suction, then it says, okay, the suction has reached the preset level. So you can go ahead, the machine is working properly. But we never fail. To be frank, we never fail. Very, very rare to fail. Even failing also, if you don't pinch it properly, you fail it. Otherwise, you never fail in the test. So a test which has not failed many times, the metallurgic Mr. Ross, he said there is no point in having test. So he removed the test from his machine, saying that this test was never failed any time by any surgeon. So there is, what is the point of doing this? So he removed the suction test. What I found is the suction loss most of the times, when what I had troubles is this internal uh, passage for the air, and in the suction cup somewhere there will be block here, not in the tubing. So the suction will be okay with the tubing. Here it will be blocked. So you don't reach full suction in the chamber, suction chamber of the ring, though the suction is there in the tubing. So those are the cases where you get a suction loss and where you get incomplete flops or you get a free caps. So I had, after sometimes we realized what we do now is after connecting the tube and suction test, we just, without putting on the patient eye, I routinely, my staff, we train them just press the suction and check how much is the suction is dropping down in the machine. It should not drop. It will drop by 100, because here the opening is very small. It will drop, but it won't drop much. It will drop by 50 to 100 number. That should be okay. If it drops too much, that means there is a blockage here in the uh, suction ring. These blockages are not permanent. Sometimes permanent, something gets blocked. Most of the time, some salts getting deposited and some conjunctival debris getting, mucus getting blocked partially. So next time when you clean it, it will disappear. So that is the trick. So that's what I found is the main cause for suction loss rather than uncooperative patient. So now the microkeratomes looks very elegant, very nice. It looks very compact, and each one is having two motors, very fine motors inside, and all are very nicely made with a high quality materials. And still, there is a life for this machine. That's what we need to understand. Once we buy, we think it is for lifelong. It's not like that. When I spoke with engineers, they said the average, this is a disposable head, of course. The reusable head, they said the life, the maximum life well maintained is 2000 to 3000 cuts. By the time, most of them get damaged. For the motor, they are given well maintained motor 3000. After that, they said you cannot reuse it, you have to use it. Or they're saying is 4 to 5 years. By the time you have to buy a new motor, you cannot keep on using the motor. Why, I will show you. For example, this microcatome has got two motors. Here is one motor, the other one is here motor. It looks like that, it looks very nice, but this is very complex. The motor inside is very, very complex. It's got so many gears, so many inside electronics, and they are continuously monitoring the temperature, they are monitoring the speed and the torque and the amperage and giving feedback to the machine. And the gears are so many are there inside. This is called planetary gear system. This is the motor, actually what this drawing shows. And this is the planetary gear system which is attached in front of the motor. Most of these motors are manufactured by now by only one company from Switzerland. Uh, I don't know how they pronounce, or Harbor maybe. They make all, for all, even microscopes or for everything. You see the number of gears inside. So they lubricated ones. They presume that 4 to 5 years down the line, this quality will come down and they get the life is over. And they supply for everyone. They supply for ML7, they supply for Amadeus, they supply for all top companies in the world, the motors. Then coming back to complication, I don't want to show any complications in my presentation because there is a subsequent, all complications I had. whatever written in the books I had in my practice without any exception. Buttonholes, irregular flaps, incomplete flaps, free flaps, epithelial defects. But one thing what we noticed in my practice is all they happen in the first 100 flaps. So they said it is a learning curve. It's not learning curve. Even you change a microkeratome, when you buy a new one, you get all the problems in the first cases. It is tuning in period, just like these are brand new mechanical parts given to you. They are not in coordination with each other. So what I am doing right now is, of course, I didn't change my microkeratome for more than 4 5 years. So whenever I buy a new microkeratome, I put the blade, I do dry run. Dry run means without patient or with the silicone balls. If the company gives, Schwinn gives silicone balls, 50 to 60 times I cut each head and each motor. I use 50 to 60 times dry run uh, on, uh, on not on patient, just I run it so that all will become uh, coordinated with each other mechanically, and they become more in synchronization, and all irregularities, small things will get smoothened out. So the buttonhole, to be frank, my third patient I had buttonhole, and the irregular for incomplete flap, my boss Dr. Srinivasan, he bought a microkeratome. One doctor from Singapore, he came to assist to help him out. First patient, they had a free cap. The first cut, his friend and his friend daughter, first patient, he had a free cap with handstone. So they stopped. They took the handstone machine back to Singapore to recheck where is it gone wrong. So that's what I found. Whichever microkeratome, when I collected the surgeons, so whenever they first cut it, always the problems are there. All this happened. So first 30 to 40 cases, I do it, then rare we get the problems. Then there are certain rules in which it can happen. Uh, for example, a steeper cornea is more than 48. Though I did LASIK up to 50 diopters cornea, generally it is given in the books that if a cornea is more steep, more than 48 diopters, then you are likely to get a buttonhole. And dry spots, of course, during early stages of our practice, we forget to put a drop of saline, BSS, on the cornea when you are putting a flap. But most of the engineers, when I spoke with the who manufacture microkeratomes, they do not advise BSS and uh, normal saline during flap cutting. They advise distilled water because these normal saline all contain salts. They say they are not good for the microkeratome head and microkeratome motor. They recommend only distilled water. They say please use distilled water. Don't use uh, BSS or uh, ringer lactate. Especially ringer lactate is more dangerous because it's acidic when compared with the BSS. Then the somehow second eye complications are more common than the first eye. Uh, we don't know. When you cut right eye, it's fine. So when you cut left eye, problem comes. So much so, my cousin, as I told you, K.P.Reddy is one of the pioneers. He started cutting left eye first. He says left eye problems are more. So even now, he's cutting left eye first. One of the few surgeons I saw. Then he cuts his right eye of the patients. He became like that mindset. The right eye when I cut, the left eye always problem. Let me finish left eye first. He cuts the left eye first. Uh, this is the another problem that we saw. That irrigating, as I told you. So when you have some problems, that's this one. We just do not do nowadays laser. We just postpone the surgery. Any problem we postpone. Previously we used to do go ahead and do something, but no more. So the mechanism explained by the one for the buttonhole is if you have very steep cornea, when you accumulate, it's okay because you are flattening it. So they say beyond one point, there will be excess corneal tissue when you flatten. that buckles up. So in the center. So because it's a spherical structure, when you make it flatten, if there is a excess somewhere it has to accommodate. So there is no place for it to accommodate the central excess. There is a more tissue, whereas in opening, it becomes the cord length is less when compared with the arc length. This we call it as arc length, and this is called as cord length. So when arc length is always more than the cord length, so when the cord is very steep, 48, 49, this is the arc length is excessively more, so it buckles up. So the microkeratome blade goes straight, so you will have a buttonhole. That's what the engineers explained to me when we asked them. Then comes to the free flap. It's not very unusual with Moria. Moria is notorious for free flaps, especially in Indian eyes and in flat corneas. Anything less than 42, even not even 42, 43, you have almost 30% chance you will land up with a free cap in Moria. If you follow their company nomogram, almost 100% you will get a free cap in Moria, because the nomogram is developed for European eyes, not for Indian eyes. Indian eyes white to white is almost 1 millimeter, 0.7 millimeters smaller than the European eyes. I had at least 2 to 3 caps in Moria. So now we change, we don't use the ring what they suggested. We use a smaller ring, or we use 7.5. We don't put 8 stop as they are recommended by Moria. We put 7.5 stop. Rarely we use 8 stop. And small corneas. If we have Lanemo cornea, we don't use. Usually we try to go for a PRK or some other procedure. And then coming back with the suction loss, anything can happen. Irregular flap, buttonhole, piecemeal caps, or if, free flap. Anything can happen with suction loss. So what are the areas where you can safely do without very confidence, especially for beginners? Not even 42. I recommend 43 to 46 is very safe. 42 to 47, 48 is doable. Less than 42 and 48, better to avoid. And corneal diameter again 11 to 12, 12.5 is very fine. And if your diameter is very large, like 14 millimeters or 13.5, very unusual. But if you have, and less than 11, please do not do flops in those cases with microkeratome. And the clean conjunctiva, if you have pincicula or a prior surgery was done on conjunctiva, and if you have a pterygium or any other nodular things in the cornea, so please do not try in your first few cases. As usual, deep eyes you better avoid in first few cases. So, which of the cases are very risky? K reading less than 40, never attempt, even experienced surgeons. K readings more than 48, K, of course, you can go up to 50. I just put as a 48 as a one. Very deep seated eyes, and a corneal diameter less than 9 millimeter, corneal diameter more than 14. This less than 10 to 8, 9 doing flop is possible, but you should have a lot of rings in your hand. You have different ring size. Usually we'll have 2 or 3. With that you cannot do it. Unless you have an array of rings, you cannot do it. And as I told you, pincicula, pterygium, even prior spoon surgery, prior RD surgeries, better to avoid. You can do, but better to avoid making flops. So what I learned in my practice with the complications is, as I told you, checking the suction, not by protocol given by the company, which the company says just pinch the tube and do it. That's almost useless. That's almost good for nothing. So you have to connect to the entire uh, suction ring. Then no need to, if you can occlude the suction ring with your something in the bottom, that's wonderful. And check the suction. Even if it's not possible, just press the suction switch and see how much it is dropping. If the suction is not dropping without putting on the eye, just in the air, that means there is some blockage in the tubing. It will drop by some volume, some 50 to 60, depending upon each company, but it should not drop dramatically. That's help because you don't get complication in every day. You get once in a year, maybe once in 2 years. Even that can be avoided. So another important thing I learned is still we do that mistake because we would be such a simple surgery. You have done so many overconfidence. Once the vacuum is reached, the staff says yes, vacuum is reached. Some machines they give the vacuum has reached command they will give. For example, Amadeus. Moria doesn't talk anything. Moria keeps quiet, and Pendular gives a nice beep sound. Clicking like that, it will give two tones. So that means it is reached. So Moria, you have to look into the monitor to see the number, whether it reached 132 or 131, 135. So once it reaches the final level, before you initiate cut, if you wait for 5 to second, 10 seconds, if you can wait for 10 seconds, that is beautiful. So whatever suction loss that comes with incomplete suctions and the loss of suctions, all will happen during this time. So then you start cutting. If you can wait for the 10 to 15 seconds for each patient, you never get suction loss problems. Whatever patient squeezes, does anything, it will never come out. So all these problems will be solved instead of cutting immediately. Generally, what I saw is within 2 seconds we start cutting the flap once the suction is reached. So anything different happens. Please do not do the next time. For example, if you are not happy with the flop in one eye, you got the flop, but you are not happy with the quality of the flop or with the suction or thickness, or it looks very thin, but you got a flop, you got a nice bed, you finish the surgery, but it is very thin flop, or it is got some very small hinge, and you are not happy with that thing. So the next time, don't use the same instrument, same setting. You have to completely relook. Most of the my cases, okay, I got it, though it is not ideal, I got it. I may get the same thing other eye I did, so I land up in terrible problem second eye. So that's what I learned. And the second thing is, if it is always wonderful to have everything two sets, not the microcatome console, cable, motor, uh, head, and everything. But it's pretty expensive. That's unless you have a group practice, you cannot have so many things. Each motor is 7 lakhs. Each head is 1.5 to 2 lakhs. Each ring itself is 2 lakhs. So that's another limitation. But when I bought in 2001, we had all two sets. At that time, it's not that expensive. They used to give for a reasonable price. We bought all two sets, two motors, two. So if something happens, we used to put second tubing, second cable, everything for the other. So another thing is what of late we learned. If you want a long life, you can do ETO sterilization. That is much better than doing autoclaving. Given the rings, uh, head, microkeratome head, rings, everything. If you do gas sterilization and don't allow the moisture to settle down, your life is excellent, beautiful. You will get 3 times the life than sterilized instruments. Then keeping the motor, once the surgery is finished, you clean the motor, you keep it. Whatever you do it will suck some amount of moisture inside it. So keeping the motor upright position is very helpful. It will drip off. All the solutions will drip off. And during the storage time, the atmosphere should be very dry. For places like Bangalore, it's okay, your humidity is less. But in places like Chennai, in Nellore, in my place, our relative humidity sometimes when it rains always 80, 90. So whatever moisture get deposited, so it will spoil the uh, both motor and the gas inside the head. So what we learned is better to keep the LASIK motor and head everything after cleaning and after sterilizing or before sterilization inside the LASIK room, because in the LASIK room we are always maintaining air conditioner and humidity. If you keep these instruments, they are better maintained than keeping in a storeroom outside, which is a not atmosphere well maintained. So of late, I started doing a temporal hinge instead of microkeratome, instead of superior and nasal hinge. So we had when we took a lot of photographs, what we found, the pupil is always displaced a little bit more nasally and superiorly than uh, temporally and inferiorly. So most of our procedures are pupil based. We are doing excimer laser with a pupil tracking. So the ablation is placed around the pupil, even if you decenter for angle alpha or whatever you do it, whatever your fancy thing, you don't do more than 500 microns. Uh, Generally 200, 300. That's very negligible. That's almost, in my opinion, except in hyperopia, it's almost peanuts. It may give a little bit very negligible quality of vision. So this, when we I am of the opinion, when you make a nasal flap or a superior flap, there will be some amount of hinge ablation, especially when you are doing astigmatism, eye adapters. So that's what when we found when you took the lot of refractive surgery patient eyes and we measured these distances, we found temporarily we got a lot of place. We have a lot of space. So one of my fellow, Dr. Amaya, he's very good in mathematics, so I don't know anything about it. He calculated with a lot of his calculation maths, and he came out that it's giving me almost 30 to 40% more bed area, a temporal hinge, when compared with both superior and nasal hinge. In his calculations, even nasal hinge is giving little better uh, ablation area than superior hinge. So this what we are doing now. This ML7 is very nice. We can do a very nice temporal hinge where it's not possible with Moria. And as you can see, it goes and it comes out nicely. And the flop, when you lift the flop, this is a temporal hinge. So when you have very nice almost circular, very nice area for ablation, even for hyperopia. If you are doing 4 5 or 6 depth hyperopia, also you get a very nice bed when you do a temporal hinge. Well, when I do a astigmatism, I look at the ablation profile. If it is coming more what horizontally oval, then I take a superior hinge. If it is coming vertically oval, then I take a temporal hinge depending upon the astigmatism of the patient. And in hyperopes, I do always, even if I do femto flop, I am taking nowadays a temporal hinge, then a superior hinge. And as I believe that if you know the basics, I mean some concepts which some of you we are as the doctors are missing, we'll be thinking and correcting ourselves. Then if I just show some complications and you do this, you get it, you do this, because all the complications I had, I have no answer. So uh, flap infiltrate, though we didn't had a bad infection, we had flop infiltrate, we had a DLK, we had irregular flops. So when we analyzed why we got like that, very few points we found where we did wrong. Uh, uh, I don't much believe in hypothetical answers. Uh, so that's the reason I didn't quote whatever given in the books. You do this, you don't get this. You don't do you do this, you don't get that. So all that we are reading, everyone is reading and keeping in our mind. But when you are practicing, uh, most of the things are given. So that's why I try to answer some of the problems which we cannot solve in a different way and put before you. And I want your also opinion also, because you have a great experience with Amadeus. I used a few, if not many, cartoons as Dr. Deepthi has mentioned. So I started my surgery with the CB, carriage Barakat from Shin, and I used pendula and handstone and Moria 2, Moria SBK, and Nidec, and now I'm using ML7. That's quite a good number of cases. So whatever been different microkeratomes what we learned over a period of time. The- I used Amadeus, but very few cases, maybe 10, 20 cases. That's all. Thank you for again this opportunity, and we can have discussion.
Thank you so much, Dr. J.K.Reddy, sir. It was such a treat to listen to you. And thank you for dissecting out the microkeratome and a beautiful, beautiful tour of the machine, sir. Excellent. Lot of practical and technical learning. Thank you so much. So I invite Dr. Jyothi to discuss about the Amadeus. So in the meanwhile, Dr. J.K. Reddy sir, there are a few questions. So one is like if you have realized there's a free flap and you have gone to the other end, what is the best way to release the flap and put it back? Any practical tips on what do you do as soon as you realize there's a free flap?
For me or for Dr. Jyothi?
For you, sir.
For me? Yeah. See, I had free flaps, but somehow, don't ask me why, this marking on the flaps and measuring IOP with a appellation, Baraker appellation head, appellator, at the few things we never did. I never did, and in my practice, one is marking the line on the cornea, and second thing, one you put a lines, on the marker pen. That I never did. Second thing is the after suction is reached, measuring the IOP whether the suction is reached or not. I had so many those things supplied by the company. I never used it. And the third thing is uh, making the checking the pachymetry at the end of appellation. So when I had a free cap, so which side we can find out, because I'm a corneal surgeon trained for so many years, which is epithelium, which is a stromal side, I can find out. But only thing is the orientation of the flap. So whatever said and done, you never get a perfect round circular flaps. Very, very unusual. So you can always find a sweet, you can always rotate and find a most appropriate shape which they fit in. Uh, Many times we just leave the bandage contact lens. We do ablation. We don't stop ablation. When you get a free cap, we complete ablation unless it's a small cap. If it's a more than 6 millimeter, we finish the ablation, then we put the flap, and we leave it bandage contact lens for 5 days. But once my friend called me in half of the surgery, he said he had a free clap he is not able to find in Moria. The problem with the Moria is it is a polycarbonate head, transparent. The cornea is also transparent, you can't see it. So then I told him, take a tripon glue and put a drop and see it. Then he said it is there. Once you put, because it picks up the stain, blue stain against the yellow, you see very nicely.
Dr. Reddy, can I butt in, Deepthi, just a little bit?
Yes,
questions. Yeah. I'm Prashant and from Bangalore, and I mean, very nice talk about the entire history of this thing. Very interesting to note that microkeratomes were initially with turbines run by compressed gas, and now they are into micromechanics, and the motors have come in. Why do you think the motors came in instead of gas? Was it because of
convenience? Convenience. Number one,
convenience.
You should have a big nitrogen cylinder sitting there. Number one, it's a bit noisy also. It makes a lot of noise. And something and very small size. The turbines are quite big.
Okay.
These microkeratomes are very small, and you cannot have two motors. But my friend, one of my friend, Dr. Gopal Razu, you might have heard in Vizag, he started CB with turbine initially, where the he has to forward pivotal action, but he has to do with the hand. But he
Okay.
swears he got the best cuts ever possible, ever he saw in his life with a turbine. Turbine is very powerful.
Hmm.
Like a small glitches here and there, salts here and there cannot slow like they slow the DC motor.
That's one thing. And second
And in
thing,
the tubing also very heavy. The
okay.
tubing goes for the turbine. It's real heavy on your hand. It's not.
Because even the vitrectomy machines all started with the vitrectomy cutters all started with compressed gas and nitrogen only. And I think even till today, most of the good vitrectomy probes are still having gas-driven cutters. So that the mechanical cutters never probably work well in vitrectomy machines. Anyway, that's one point. The second point, you have gone through so many microkeratomes. I mean, you explained all about the cutting and all that. What about the suction part? Suction part, was there any big change in the technology from the beginning to now? And because I feel
Each
suction is
one.
the most important part, which couples the microkeratome to the eye and causes the maximum amount of warping or change of the corneal, I mean the eye shape during the cutting. I
See,
mean, has there been
somehow
a big
that's another very important point. What you asked is very important point. What I realized is uh, the suction chamber volume they are changing. So, for example, in Pendular in Schwinn, he uses such a large suction chamber volume because his microkeratome is not planar. It's dips into the cornea. By it took almost 6 years for. See, initially I paid money for Carriaggio. I could never get that. So I lost a lot of money. So we are sitting with Caesar Carriaggio. Why you are not giving us? So it took so much. We lost the money. So we took an alternate old one. So they never paid us back the money which we paid. So they said, we given you one more microcarton. So the suction chamber, what he did is he made a huge suction chamber, thinking that the amount of suction chamber which used by microkeratomes is the cause for suction loss. Actually, my thinking is not the cause; it is the amount of suction they are using. Somehow, people thought that high negative suction is bad for the eye, but I don't believe in that. You can use high suction if they can allow a little bit more suction. So you get rid of all these problems of suction loss, irregular flops, all the problems. So they reduce the companies, people reduce the bare level to the suction, which by calculation they came to some conclusion that is very safe to the ocular uh, nerve, optic nerve perfusion.
and okay, very interesting. And the other thing is the rising of the intraocular pressure. Is that a need for every cut, or is it a byproduct of changing the eye shape and compressing the cornea? What do you think
No,
is
no,
the
you need intraocular pressure is very essential for uplenating the cornea onto the see basically cornea is a spherical and you are want to make it a flat. It's impossible. A spherical structure cannot be made flat. So we are using very high intraocular pressure and making that flat. See, that is one of the greatest advantages of Amadeus uh, because it is so heavy. Number one, the weight itself is produces a lot of pressure on the eye and it raises the intraocular pressure. The Amadeus itself is very heavy. When though it is a titanium make, it's quite heavy when compared with any other ML7 or
polycarbonate?
anything. And
Polycarbonate.
second thing is the way you hold itself, you, you have to press on the cornea. There is no way the way you are holding it. So that's why the flops in the medias are so smooth.
Thank you so much. And coming to the the Amadeus, which is probably the only microkeratome we have used since ever since the 20-25 years that we've been in service now. But I mean, so many people have used Amadeus in our center, and we have not had many complications. Anyway, Dr. Jyothi is there. She's waiting to go ahead with the Amadeus presentation. I will stop at this point. Thank you so much for such a beautiful presentation and answering all the questions. Thank you so much. Dr. Jyothi, I think it will take over. Deepthi, you want to talk something about?
Yeah. So thank you, and we'll keep taking questions as we go. And I heartily welcome Dr. Jyothi. She has probably used Amadeus, I don't know, close to how many decades you have been using, Dr. Jyothi?
20 years.
20 years, wow. So I think no better than her to take us through her tips and what she feels with this microkeratome. Welcome you, Dr. Jyothi.
Good evening. Can you hear me, Deepthi?
Yes.
Yeah, yes.
Perfect.
Yeah. So good evening. Let me give you a brief introduction to Amadeus. We've had a exhaustive and rather interesting talks in which we learned a lot of things about microkeratomes. So we will look into what is Amadeus microkeratome. Then, 1 minute. Just. Okay. So this is how an Amadeus microkeratome looks like. Since 2001, we have been using Amadeus microkeratome. Initially, we were using Amadeus 1 with 160 micron depth plate. And currently, we have upgraded to Amadeus 2 with 140 microns. So basically, this is the suction unit, vacuum unit, and this is the motor. And you have a blade that goes into the blade holder. And you fasten the blade holder into the motor unit. Okay. And you also have a touchscreen control panel. I will come to it a little bit later. So you can customize the various parameters on the microkeratome. And there are 2 foot pedals. One is green and one is red. So in between the cut, if you have any issue, you can always abort the procedure by using the red foot pedal. But otherwise, it is the green foot pedal that you will have to use all the time. So basically, the motor unit, it has 2 motors. One is for the translation of the microkeratome and one is for oscillation of the blade. And there is an array of ring sizes varying from 8.5 to 10 ring size. We have 8, 9 and 9.5. And various depth plates are also available in 140, 160 and 180 microns. And also you have the 2 foot pedals. So coming to the control panel. So you have the first parameter is the blade oscillation frequency. And we generally set it at 10,000 RPM by default. And for 140 microns, that is supposed to be one of the best blade advancement frequency to be kept. And then the blade advancement rate, we usually keep it at 2. This is 3 here. And flap diameter, you will have to enter it manually depending on what flap you're using. And hinge width is generally kept at 0.8. Okay, there are exceptions. I will come to that later. So basically, these 2 are preset. So you don't have to do anything. But then sometimes this is a touch screen. So it is better as a surgeon, you have a look at the microkeratome control panel before you start the surgery. And you should be aware of these values so that you will know that, nothing has been changed or nothing is amiss. And suppose you are using a 9 flap for right eye. When you come to the left eye, you want to use an 8.5. So please make sure that you change it in the microkeratome also. So you should not forget doing that. So when you have a flat cornea, like Dr. J.K.Reddy was mentioning, so we have to be careful to avoid a free flap. So we generally use a 9.5 ring if the cornea is less than 42, and we keep the hinge at 1 millimeter, and preferably a fresh blade is used. So that will reduce the incidence of free flap. I have had 1 free flap in this 20 years. So the Amadeus is very forgiving that way. I haven't seen even my colleagues, so many people operate here. Hardly maybe 0.1% of people only would have had a free flap. And buttonhole I haven't seen. So we will, in the Ulta parameters, you will have to reduce the hinge. Even if it is 45, I keep it as 0.7, or if it is more than 46.6. And then a smaller ring size would reduce the risk of buttonhole rather than a big ring in case of a flat cornea. So these things, if you are aware, it is better rather than depending on the technician. So normally we don't, if you are not doing LASIK very frequently, you may not even pay attention to the hinge width. But when you have a cornea which is less than 42, or if it is greater than 46, you should be careful, and you have to take care of these parameters. So see the control panel, you have all these parameters such as oscillation frequency and blade advancement rate. So these settings you can play around a little bit if you are familiar with your machine for high flap accuracy. So if you want to have 140 micron cut, so this is some studies, most of the studies have found as you increase the RPM. So once you increase the RPM, you get a better cut, and you have to reduce the head advancement rate also. So that this is supposed to be optimum for 140, and we are following almost similar parameters, and we have had a good experience with the same parameters. 2, we use it here. So the main advantages of Amadeus, it is a very, very user-friendly microkeratome, especially for beginners. Okay, you can operate it with a single hand. And when the attendant give you the OT assistant, give you the microkeratome, it is fully assembled. So you use a fully assembled microkeratome onto the cornea. So on the eye, you are not doing any procedure, and this will reduce the suction time also. And we have heard of gear jams in microkeratome. In Amadeus, there are no gears, and so no gear jam. And the applanation plate here is visible throughout the surgery. So since we can see, I would recommend you stay glued onto the microscope and keep looking at the, as the cut proceeds, keep looking at the microkeratome. You can also see the pupillary dilatation, so which will assure you, okay, the suction level is attained. So there is a talking algorithm on Amadeus too. But even if that is not there, by seeing the pupil dilation, you know that the suction level is achieved. And then this produces a nasal hinge. So all of us are familiar with nasal hinge, and even the talking algorithm will tell you remind you to lubricate the cornea. We use 1 or 2 drops of distilled water. Earlier we used to use BSS or RL, and we were asked not to use those things, and so we use very few drops now. Previously we were lubricating it quite a bit. So we had done a study on flap thickness in JLVC. I had done it with Dr. Ravindra sir. This was in 2005 or so. So we had used an Amadeus 1 microkeratome, and we were trying to find out what are the parameters that affect the flap thickness. So a couple of findings came out of this study. We had presented it in KOS also. The flap of the second eye was consistently thinner by about 20 microns. Okay, so this made us start reuse of blade after ETO if we wanted thinner flaps. And we also started doing the eye. If you have an eye with lesser power and more power, we always cut the eye irrespective of right or left with the lesser power first, and the eye with higher power, we cut it second so as to get a thinner flap. And by the reuse of ETO blades, we were able to customize the flap thickness we used to get flaps as thin as 100 microns. So initially we were not measuring the flap thickness, and we assumed that since it is written 160, all our flaps are 160. So we never bothered to measure the flap. That is in the first few years. So after we started measuring the flap by subtraction pachymetry, so after measuring the flap, we realized that our flap thickness was quite variable between 160, it was not 160, sometimes it was 180, and also it was 200 at times. So that was a red flag for us. And also there was a surgeon factor. We found that the flaps taken by certain surgeons who tend to push in the microkeratome more, they had consistently high flap compared to people who did not press the microkeratome before the suction was achieved. And we also found that thicker cornea gave thicker flap, and that is good actually, thinner cornea giving thinner flaps. And later, several studies were published about flap thickness, and we found most of our results were agreeing with those published studies also. And so this is also one of the reasons why we switched over to 140 micron. And the flap thickness was measured by subtraction pachymetry. So we used to measure the flap, the cornea just before the procedure, and after lifting the flap, we again measured. So then we got the flap thickness. At that time, we did not have the anterior segment OCT. Probably now we should do a study with this depth plate with anterior segment OCT to measure the flap thickness. This is a short video of Amadeus, working of the Amadeus microkeratome. So we have to ensure the exposure is adequate so that the movement is perfect. And we also need to inspect the conjunctiva to see any debris from the cutting of drape or eyelash or conjunctival secretion is there. So if all these get inside during the movement of microkeratome, you may have a suction loss, and you may also have a pseudo suction with flap problems. So in this, we have to press the foot pedal 4 times. First is test, and then it will achieve the 0 position. Then the cut is made, and then the vacuum level. After the vacuum level is attained, the cut is made. And we can see on the screen when the vacuum level is obtained. The corneal marking, we are not practicing it. And positioning of the patient is also important, not only from the laser point of view. If you have to place the horizontal, the microkeratome horizontally, then you will have to have the head straight, and that would be the best position to place the microkeratome. If the patient is bending either this way or that way, then you will have difficulty in placing the microkeratome. Especially for beginning surgeons, these factors have to be taken care of. So, what we have learned from our collective experience, it is not the experience of one surgeon, it's the experience of many surgeons. See, initially, sometime we get the blade from various sources. We used to see few blade particle deposit in the stroma. When you see in the slit lamp, the cornea will be shining with those few particles here and there. So you have to check the blade even if it is a new blade. And we do a dry run with fluid so that if any debris is there or any particles are there, they are washed off and it will not be in the stroma. And it will also test the microkeratome. We always do a dry run. And if it is an etude blade or any blade, we inspect it under the microscope before the blade is put in the blade holder. And we of course have to check the parameters as I have mentioned. And you need to instruct the patient what to expect. You will, if the patient abruptly move the eye, that it may not be a good thing. And patient, you should ensure adequate exposure. You will have to position the speculum in such a way that there is sufficient space for the blade to move smoothly without getting stuck anywhere. And you use the appropriate suction ring. And when you hold the microkeratome, you have to hold it firm on the eye. You should not push it down. See, in the initial stages, you don't want a suction loss and you want to be careful and you have a tendency to push the microkeratome down. Please don't do that. Just hold it firm, just enough to hold it. And once the suction is achieved, you don't even have to exert any pressure. It will hold on its own. And 1 or 2 drops of distilled water definitely helps in the smoother passage. And during the cut, you keep looking at it, because if sometimes, God forbid, you have a free cap, you don't want the, see, we will in a busy LASIK day, you will continuously keep having cases. And once the microkeratome is done, the attender will take it away. So you don't want the attender to carry the microkeratome with the corneal flap away. So you will have to keep watching and be careful, and so that you will not lose the flap. And after the procedure also, wait for the suction to be released before you remove the microkeratome. Don't be in a hurry to just take out the microkeratome after you finish the cut. So that's it from me. Thank you.
Thank you. Thank you, Dr. Jyothi. Very, very practical tips. Thank you so much for sharing. So now we have a few complications, which how we managed. It's very quick complication compilation that we have done. So we'll start with Dr. Sharon. So Dr. Sharon, are you here? Hi, so you'll have to unmute Sharon.
Yes, done.
You can start your screen share. So hearty welcome, Sharon. Dr. Sharon is a consultant cornea refractive surgery, and her passion is ocular surface. So she's a consultant at Narayan Nethralaya. She's also pursuing her PhD and a very sweet and close friend of mine, and an excellent clinician and surgeon. So Dr. Sharon, can you just brief us about the LASIK complications and what 1 or 2 complications that you would want to tell us, and how did you manage it so that if one of us are faced with that, we are a little more confident after that?
Right. Thank you so much to Dr. Deepthi and the entire JLVC team. It's an absolute pleasure being here. As Dr. Prashant was saying, it's been too long since we've all met in person, but at least we have these meetings. So 2 great talks by Dr. J.K.Reddy and Dr. Jyothi. And I agree, knowing your machine is really more than half the battle won. For example, the simple tip about the Amadeus versus the other. So the Hansatome needs an on-eye assembly compared to the Amadeus, which has a fully assembled microkeratome when you get it. And knowing that and how many foot pedals and how many times to press the pedals, like the Amadeus, you press 4 times. You can do it, put it off if you require, whereas the Hansatome or the Moria, you need to have a front back pedal. Those small things are extremely important. That being said, and another good thing is that the complications we see with LASIK are very, very rare. Most of us would have seen just a few, and that too very few and far between. But it's important to know that if they happen, how we should manage them. And I'll just it's a very brief talk on a few of them, and which will be followed by Dr. Deepthi and others with a few of the others. So these are the main flap-related complications that we could see in our practice. Of course, the intraoperative ones are the ones which strike fear in our hearts, whether be the incomplete flap, free flap, buttonhole, completely dislocated flap, or the side-threatening corneal perforation, and a relatively minor epithelial defect. But there are a number of post-operative ones which can happen and are more common than we even realize sometimes, like the flap striae, epithelial ingrowth, or the GLK. So we'll just be running through a few of them, and we can have a discussion as and when. Definitely flap striae is one of the most common ones that you would see, and most of the time they're extremely fine on what we call the microstriae. And I am sure some of our speakers going forward are speaking about this, but mainly we see it if the flap is very thin or the patient has rubbed the eye in the early post-op period. And you don't usually have to do anything unless it's visually significant. And if it is, then better to do something early to avoid fixed striae. Okay. But this is a patient whom I saw. Actually, he was a 25-year-old boy who had undergone a LASIK, and he was perfectly fine on the first day post-op. But at 1 week post the surgery, he complained of blurring vision and irritation. And as luck would have it, he was a patient who was from out of station. But anyway, they came in, and when they did, I saw to my dismay that this LASIK flap was folded, as is quite apparent here. This is the fold quite near the center of the visual axis, and it's folded inwards. This is the vertical line, if it's not visible on the screen, and it's folded inwards. On an ASO3, it's much more visible, but even clinically, because it's such a large fold, there's really no way to miss it. So another thing which is very important to realize is that the epithelium grows in very, very fast. So in this 1 week, what had happened is from the flap, the residual, the edge which was there, the epithelium has now covered this entire stromal bed till the flap fold. So that is very important to realize, because in our management, if we do not tackle this epithelium which has grown in as well, then we're going to have further complications going forward. So what we did for this patient is just this quick video to show. So the first thing is to try and remove the overgrown epithelium. And it's very important to go much beyond, even beyond the flap edge. Then lift the flap up gently. Now there will be some amount of edema of the flap, and these flaps are a little friable. So it's important to lift it quite gently, but not at all difficult to lift. Then iron out the flap on the stromal side. What I've used is using dry Miracell sponges, but you can use any instruments. And I'm sure Deepthi will show a very interesting technique that she uses as well. But what is most important is to, again, put the flap back after you've ironed from the stromal side and do it on the epithelium side as well. You have to do this multiple times. And when you're doing the ironing out from the epithelium side, it is important to try and remove the epithelium from the groove which is there. I'm just rewinding it just to show this part. 1 second. Yeah, so on the epithelial side, try and remove the epithelium which has grown into that groove or the flap fold, because otherwise your flap stria or flap fold is not going to go away. So that's extremely important. And even though this is a highly edited video, you have to do this multiple times. And it's easier said than done because flap is, quite edematous and you could tear the flap inadvertently. But if you take care of all these measures, then you can get an excellent result with hardly the flap showing at all and near normal vision, because at the end of it, these are refractive surgery patients. So they're always concerned about that post-operative vision. Now a twist to this scenario, because there it's in the operation theater, it's under a very controlled kind of environment. We can put a speculum, everything is good. But this was a gentleman who actually came to our hospital. He had a LASIK surgery 10 years back, and then he had an RTA with head injury. And at the time of the RTA, he had a loss of consciousness as well. And because of his injury to the side of the face and the eye, he was brought to the hospital. At presentation, he was conscious but very drowsy, unable to sit at the slit lamp, was having multiple episodes of vomiting. And to my despair, when I examined him at the slit lamp, actually, I didn't even see this. What I saw was a hint of something trailing under the upper eyelid, and realized that it was a LASIK flap, which was actually under the lid, just, one very small strand attaching it to the remaining part of the flap. So I couldn't even think of putting a speculum into this eye. Plus, he had a lot of lacerations around. So we had the attender hold him to the, at the slit lamp for a few minutes. And I just pulled the flap down and did as close an anatomic approximation as possible, because there was no question of, taking him to OT or anything like that, and said, okay, this is the least of his problems. He needs to be referred to a specialty hospital, but let's try and salvage the flap the best way we can and live to fight another day. So you can see that the main idea is to try and find the anatomic orientation. So this is where it's just attached, and you can see the area where it's torn off. So once I unfolded the remaining part of the flap, I could find that, I'd be able to approximate it. So I put it into that position and let it dry for a while and put on a BCL. But the cornea always surprises us. And after we referred him to the specialty hospital, I just put a BCL there and I referred him. And when he recovered a little bit to come in for a follow-up, at 1 week, the cornea looked much more pristine. And we probably, at later date, we may need to do something if he has a lot of scarring, but as of now, he's doing well. So the idea being that sometimes we can't even put a speculum or can't even do anything. You just have to hold the eye and do the best. But there's always, the cornea is very forgiving in our attempts to heal it. Another important complication, post-operative complication that we see is epithelial ingrowth. And it's important to recognize it and know when to treat it. So just to give a brief idea, there's something called the Machart classification of epithelial ingrowth. And there's grade 1, 2, 3. Very briefly, the grade 1 is just very small aggregates which are near the flap edge, within 2 millimeters of the flap edge. It usually doesn't cause any vision-related problems. It doesn't cause any flap-related problems and doesn't require treatment. As this gets worse, the pearly nests of the epithelial cell nests are much more clearly demarcated. So as it increases, we need to think of doing more. And in the most severe case, you can have the flap edge being pulled away from its position. The flap edge can melt, and those, of course, need to be treated early. So there are two ways that you can manage if you need to, and the more common one, because we usually only handle the ones which are much worse, so is to lift the flap and debride it. But lately there has been a lot of discussion on using the anti-yag laser, where you start with a very basic pulse. So this is the worst situation, where you see that there's a large area of epithelial ingrowth, not only in this area, the main area which is seen, but if you look closely, you can see that both nasal and temporal, there's a lot of cellness. And what is important to note is this leading edge, which you see even in the very fine areas of cellness, and you know that this is going to progress. And this patient also had a lot of changes at the flap edge, which was getting pulled away. So we thought to try and do something for this before it got worse. Here it's important again to, if you see the epithelium growing over the flap, you have to remove that. Lift the flap, and these are again very friable flaps, so it's important to take care. Here you can very clearly see the irregular stromal bed, which is all the epithelium which has heaped up there. And it's important to meticulously try and clean out that part. Then you have to remove it from the stromal surface of the flap. After you've done an extremely meticulous debridement, you can use mitomycin C. There's also been noted you can use PTK to try and remove any residual cellness, and then wash it thoroughly and put the flap back. Post-operatively, you do get good results, but the chance of an epithelial ingrowth recurring is also high, and we need to keep these patients on close follow-up. If it's not that bad, we can also have other options. So this is a patient in whom I did a limited YAG laser. And the way to do it is to start at the very, very lowest energy that you have on your machine. Aim at the area of scar and slightly defocus. And the end point is these small white marks and cavitation bubbles that you see within the scar. So the idea is to do either at the leading edge and a few within the ingrowth as well. So this was a patient, we thought if it doesn't stop with that, we will go forward and lift the flap. But if you can see, it's become much more well demarcated, and there are these areas of clearing as well, and it's started scarring. So it's a good idea to watch them very closely and then take a call what has to be done. Thank you very much for a patient listening, and I'll hand over for the other speakers and their talks.
Thank you, Sharon. Must say really tough scenarios, and what an excellent management. Great. Sharon, I think there are a few questions in the chat box.
I'll answer them.
Time, yeah. Can you reply and we can?
Yeah, sure.
So now I invite Dr. Jaya Gupta, a very high volume refractive surgeon from Delhi. So she practices at the Healing Touch Eye Care Center and is a consultant cornea and refractive surgery, and has a lot of achievements to her credit. She is very active in publications, has been an author for 3 textbook chapters and more than 5 publications. So Dr. Jaya, hearty welcome, and we would want to listen to you and how you managed your few complications, Dr. Jaya.
Okay, thank you, Deepthi. So I'll start with my screen share.
Yes, please. So Sharon, for that case where you had the flap under the lid, obviously would not have the opportunity to remove the epithelium, but it was nice to see that there was no epithelium ingrowth.
But that's still early, so we'll have to wait and watch. There's a high possibility that it may come, and we may have to remove something. Okay. But for now, it's okay. And better than a lost flap.
Yeah, great. And with the other patient with epithelial ingrowth, you did a PTK, right? So how much do you generally do? 50 microns?
Less. So if depending on how thick we think the epithelial ingrowth, you can be either 20 to 50 microns. Okay. Because anyway, we've lifted the flap and it's directly on the stromal surface. But if it's very, very irregular, then after debriding, just take a call on what has to be done.
Okay. So if you feel there are some irregularities in the cellness, that is when you're doing the PTK, not as a routine.
Not as routine. Mitomycin C though would be preferable for all.
Dr. Sharon, when Dr. Jaya Gupta is sorting out her sharing screen, can I ask you a question?
Yes, sir. Your voice is little faint.
Faint. Okay. Is it better now?
Yes, sir.
Better now. Okay. I think, yeah, Dr. Jaya started. I'll go ahead a little bit later. She started.
No, so you can ask the question, no issues.
Okay. So the question is, I'm just thinking aloud. See, the corneal flap doesn't contribute much to the structural integrity of the cornea, nor for the refractive, refractive needs of the post-LASIK cornea. Supposing you see a bad case like how you saw the road traffic accident, or a bad case of epithelial ingrowth, why don't we sacrifice the flap and just leave the cornea to epithelialize on the stromal bed?
Yeah, it's very interesting that you've asked that, and I seem to be seeing a lot of trauma. But I have seen a completely traumatically avulsed flap as well. And in that patient, we were very surprised to see that it hardly affected the vision. It's possible that that's because the flap originally might have been very thin. But yes, worst comes to worst, we've had to take such decisions, even when if there's a case of keratitis or something, we have to sacrifice the flap. So yes, worst case scenario, we may have to.
Why it has to be a worst case scenario is what I'm asking. I mean, what do you think is the problem if you just sacrifice the very bad
the
flap?
stroma may
Supposing
not
you have
be
supposing you have a very bad epithelial ingrowth, is that an option at all? I'm just thinking aloud.
The stroma may be very irregular for the epithelium to grow on. So that itself could contribute to a lot of other refractive issues later. So it wouldn't be ideal. But yes, weighing the pros and cons, if you feel the epithelial ingrowth is so bad that it cannot be salvaged at all, yes, we could. But most of the time, sir, after we've handled both from the flap side and bed side, it's adequate for an epi ingrowth.
Okay. Thank you, Dr. Sharon. Thank you.
Okay, then thanks, Deepthi. So I think my screen is visible.
Yes, yes.
Okay, so I'll be talking about the occasional issues that I've had with the SPK microkeratome from Moria, and mostly we're using the 90 micron head. So by first, I'll be talking about epithelial complications. This was a 27-year male with a refractive error of -6.25 and -0.75 cylinder in the right eye. In the left eye, -5.5 with -0.75 cylinder. Keratometry values of 46 and 47 in the right eye and 46 and 47 in the left eye. Pachymetry values were 520 and with normal intraocular pressures and fundus within normal limit. So he was taken up for wavefront optimized LASIK on 7th August. So after I finished with the first eye surgery, I noticed that there was some loose epithelium or some epithelial irregularity in the right eye. I placed a BCL and the right eye was then over. But when I was about to start with my left eye surgery, I noticed that there was again some epithelial irregularities, some loosening of epithelium. With no prior experience, I decided to proceed with the surgery. And then what happened was that the flap actually didn't cut through. And it was just an irregular cut, maybe on the screen because this image is taken along with the BCL, so it's not that visible. But if you look carefully, you can see a faint line over here. That is the edge which was cut and this entire area which was uncut. I don't have the first post-op day pictures, but on day 5, this is how the cornea looked like. And a month later, this is all the scarring that we see in the left eye. The right eye was okay, with AR values of -9 and -5.25, and refraction, what he was accepting was -4.75 with -2.5 cylinder, improving to 6 parts. A month and a half later, his ARs had settled to -5.5 and -4 cylinder. In the right eye, like I mentioned prior, this was some haze which was seen centrally, and in the left eye, you can see the edge of the flap and the scarring over here. The AR values 3 months later were as this. with 0.5 cylinder in the right eye, and the left eye was minus 4.5 with minus 3.25 cylinder. So we decided to do a streamlined PRK for him, and his uncorrected visual acuity thereby improved to 6 parts. So why does this happen? During the microkeratome pass, the epithelial layer may shift, and these intraoperative epithelial defects, they prolong the visual recovery. They cause for increased postoperative pain, also causing more of sometimes DLK, and also predisposes to epithelial ingrowth. In the long run, some of these patients also are prone for having recurrent corneal erosions. The people who have map dot fingerprint dystrophy, or elderly individuals more than 40 years old or having loose or torn epithelium, are more prone for this complication. How do we prevent it? With this particular case, the old classical teaching of one drop LASIK became absolutely relevant. So no pre-operative drops are put in the eye prior to LASIK to minimize toxic keratopathy that greatly increases the risk of epithelial defects. Topical anesthesia used should be minimized, including the length of time between application of anesthetic agent and creation of microkeratome cut. The management of epithelial complications would depend on the size and the tear, or size of the tear and its location. Mostly, if possible, we should reposition. A bandage contact lens can be placed till the epithelial defect is well sealed and covered, and plan for surgery later on. So just as like I mentioned about recurrent corneal erosions, this is another patient which had some epithelial defect at the time of surgery, and a bandage contact lens was placed, which was removed 3 days after. This was operated by some other surgeon, and I happened to see him on the 13th day when I noticed this loose epithelium after LASIK. And this was on a day later, and then again on 23rd November. This is how the eye looked like. We can see this epithelial irregularity. Also noticed interface inflammation. We can see this DLK. The epithelium though looks better. So just sharing this case to say that later on this had settled medically, but the patient still now comes to us having these epithelial defects and recurrent corneal erosions. The second situation, which is very common, though not very alarming, is what we see in these pictures, this profuse bleeding. So most of these refractive surgery patients are contact lens users, and they have this neovascularization at the edges. And the microkeratome just cuts through the vessels in the superior or the inferior pannus. In such a situation, the flap is not to be lifted immediately. A dry Medosil sponge is positioned carefully to absorb the blood, or we can leave the suction ring in place with downward pressure, tamponading the bleeding vessels. The blood should not be allowed to accumulate on the bed because of the possibility of differential hydration of the stromal bed that may result in differential ablation depths. The flap is repositioned after ablation, irrigation performed, followed by expression of fluid out from the interface. And a third situation, this is not our case, but a LASIK which was aborted elsewhere in an 18-year female. We can see the edge of the flap over here and the superior edge over here. The hinge, the flap had stopped midway. The hinge is quite in the visual axis. So with this girl, in such a situation, if an incomplete pass happens, there are two options. Either we can do a surface ablation. Since the power here was less, we opted for doing a surface ablation, or we can do it with a more deeper head, make a cut with a more deeper head. So incomplete pass happens usually due to mechanical interference by lids, speculum, or drapes. Like sir already mentioned, that with debris, conjunctiva on the suction ring tracks or the MK gear, we can have a loss of suction and an incomplete pass. So improper assembly or cleaning or more than tolerable friction in the pass of MK through the suction ring slots leads to incomplete class. If the edge of the planned ablation is, if the hinge is near the edge of the planned ablation, then we can protect the hinge and continue with the ablation. But if it is close in the visual axis or within the pupillary area, then the ablation should not be performed. The flap is replaced and we plan the surgery 3 months later. So these are only the 3 cases that I have shared. With this, I'll end.
Thank you, Dr. Jaya. Really excellently managed cases. So I think a few questions, Dr. Jaya, if you can answer it in the chat.
I'll do.
Sure, thank you. So I have a very quick 2-minute video of this patient who presented probably after a week with these striae. So let me just, can you please tell me if my voice is heard in the video?
Hello, everyone. So this was a 24-year-old.
Is it audible?
Yes, audible.
Okay.
Girl. It was 3 weeks post LASIK, a very optimistic girl who had 6 parts vision with a little complaints of halos and glare. So the question was to intervene or no. And after a lot of discussions, both of us decided we should intervene. And this was the 5-step surgery that we performed, and let's see how it went. So the first step is basically to release the macrostriae, which can be only and only performed by removal of the epithelium. So epithelial removal here was done by assistance with alcohol. The entire epithelium over the flap was removed. Ensure that the gutter has no epithelium, and also a small rim around the gutter should be epithelial free to avoid any ingrowth. So the next step is to swell up the cornea, which could be achieved by a good wash over and under the flap by distilled water. The next would be to iron out the striae. This could be very well achieved by a semi-wet 2-sponge application technique, where the sponges are massaged parallel to each other to try to iron off the striae. The 4th step is what we feel is most important, that is application of heat. So here we have used preheated hockey sticks to try to massage out the striae. The 5th would be to keep the flap stretched. This was achieved by application of 3 interrupted sutures, basically in an intention that the striae don't recoil back. So here is the end of surgery. A PCL is applied. And this is the way we heated up the instrument. A few swipes of the hockey stick over a flame is good enough, and a manual check to make sure the instruments are just optimally warm. So this was the pre-op and the 1-week post-op picture. And this slide says it all. Her main complaints were due to the higher order aberrations, which dropped from around 0.6 to around 0.3. And these are the pre and the post retro videos, which shows that the striae have totally disappeared. Thank you.
So I think, yeah, that was quite a significant striae. She probably must have rubbed her eye at a week's time. So these were the striae, and I think few tips that I really, they're very stubborn striae, and it was very heartening to see the end result. So I think few tips were, I think alcohol application is a good way to kill the epithelial cells to avoid any growths. And without removing the epithelium is not possible. So I just found this good histopath slide which shows this is a flap striae, and I think in 24 hours the epithelium goes and closes those folds. So no matter how much pressure you give, it's just impossible if you do not remove the epithelium when you're managing striae. So the second tip is always dilate your pupil, because most of our microscopes do give a good retroillumination. It's just impossible to have a look at the striae on table if you do not have a good dilated pupil. So swelling really eases on. And the third part where ironing is always around the visual axis, nothing else, around the visual axis and opposite to the striae. So this 2-sponge technique works very well. And there are a lot of papers on heat application. So ideal way described is to dip in your instruments in 65-degree temperatured water, but we tried this heating it with a lamp, and it really very practical and perfectly worked well. So as I showed in the video, heat the instruments and just check the temperature and go ahead. So this was the first case where we tried it, and I think it worked beautifully well. And we did decide to put in the sutures. We put 3 sutures opposite and adjacent to the hinge, and I think they also really helped. So thank you, and that was a small presentation from my side. So now I welcome Dr. Arun for his last presentation.
Good evening, friends. I think it's quite late now already. So I'll quickly go through something more of an experience, what I had. Is my screen being shared?
Not yet, Dr. Arun.
No?
Yes. Yes.
So this was a girl, 23-year-old girl, who came to me for LASIK surgery. And although my preference would have been a surface ablation, but unfortunately, with all the consultation with Google doctors, she had already decided, and she came for directly for LASIK. So this was her power, 2.25 minus 2.25 on both the sides, and these were the K readings and other parameters. And we decided to go ahead with the LASIK and started my case. And it was a smooth run. I finished my right eye. It was very smooth run, and it's almost picture perfect. And I was thinking of finishing the surgery on the other eye also. So when I started my second eye, the left eye, and I lifted up the microkeratome after the cut, and saw that there is something abnormal. And all the adrenal rush happened, seeing that there is no flap there. So immediately I searched the flap, and I found that it was in the microkeratome. As you know, I mean, this was my first time I had a complication like this, and it was all the theory just vanished from the brain. And it's a good thing that we operate in a center where there are experienced assistants, and we have a backup support. In fact, I immediately called Dr. Deepthi to take the idea. And as you know, the complication makes you more nervous. So I took a breath or two, and then discussed, and then later we decided to manage the case. I saw the bed, and the bed was quite smooth and nice. So I went ahead with the ablation. Actually, there are two things we could have done: one, to abort the case, or to continue with the case. So I decided to continue because the bed was smooth and I had the flap in my hand. I requested the assistant to keep it in a moist place with in the bowl. And I started with the ablation and completed the ablation. Then the challenge was to put the flap back in. So I mean, the main thing was to identify the orientation. And if we can see the flap, usually it is not exactly circular. There is a flat area. And luckily in my case, I could identify that, and I could put the flap back in. And once I put the flap back in, the identification of the epithelial surface as well as the stromal surface was also quite easy, because it's quite glossy on the surface, on the epithelial side, and it's a slightly mattish finish, like how we see the matted finished photograph. It's like that. So once I identified and placed it, it actually took up very well. We waited for about 3 to 4 minutes, a little extra long than what we wait for a regular LASIK flap. And the flap surprisingly took very well, and I put a bandage contact lens. And third day, the patient had 6/6 vision. It was very comfortable and happy with the vision. Now it's almost 3 months now, and now on the follow-up, this is what is the reading. What surprised me was the eye that actually had the free cap, had 6/6 vision with unaided. Whereas the other eye, surprisingly, she developed a cylindrical power. In fact, I've asked her to go for a pentacam, and she's yet to come back. So the entire summary of the story is basically the cornea takes up very well, and once if you place it in a proper orientation, it usually takes up very well. This is a short presentation. Thanks a lot.
Thank you, Dr. Arun Akkuri. Thank you so much. Excellently managed. So there are questions. What do we do, Dr. Prashant? Dr. J.K.Reddy, sir, are you there?
Yeah, very much.
Any closing tips, sir, with a lot of techniques coming in, a lot of...
Last case, very interesting. He has presented flap without flap with flap.
So what is your intake on the microkeratome?
Why with the flap and without the flap? Better vision than with the flap. The main thing is the hinge. My point of, I think, is the hinge problem. Either the hinge ablation or fluid in the hinge has interfered with the hydration of that particular area of stroma. So there is a differential hydration in different quadrants of the cornea, in different areas, producing a cylindrical-like picture in. Yeah, actually, it may not be cylinder. It may be a coma. It may be some higher order operations.
I think we are getting a lot of questions on free flap, sir. I think one last comment you can give. The biggest scare is what if it is stuck in the microkeratome? And how often, being a corneal surgeon, I think it's easy, but how often do you think it is required to use either a Trypan blue or something to find out what is the side?
So, what is the side? I don't think we can find out with the Trypan blue. Only we can see the flop, but flop becomes more visible with the Trypan blue. That's very good. But once you put the flop in a bowel of BSS, like DMAC, the scroll will be opposite. Here it does take up its own shape. So then once you hold with the forceps, you can put it if you can't identify epithelium. In the worst case scenario, if you can't find anything, if you are totally clueless, then you can take the flap onto your gloved finger, put on your finger, then take a Sinski or something and scrape and see. If epithelium is loosens, that is epithelial side. That is the worst case. If you are totally confused, if there is nothing is coming loosening, then that is stromal side, and epithelium nicely peels off. Don't remove entire epithelium, then again you'll be confused. Just scrape a little bit and you can check it.
Great. Dr. Jaya says, no matter what, we always still mark the flap. I think that would be the most ideal and best. So with that, I thank you, all of you, all the wonderful talks. Thank you, Dr. J.K.Reddy, for that excellent talk. I think a lot of learning points and very, very practical points in today's session. Thanks to one and all. Thank you for staying back so late. I think again it's record breaking. We are close to 11 today. Thank you, sir. Thanks, Dr. Sharon, Dr. Arun.
Thank you, Deepthi. Thank you to Dr. Prashant and Dr. Jyothi and everyone.
It was wonderful. Thank you, sir.
Thanks, Dr.
Good night.
Thanks to all on behalf of JLVC for having stayed with us for such a long time. And thank you so much. And next week we'll be back with more interesting sessions. I think Deepthi, next week's session will be on contour vision planning. So please join us same time, same day next week. And thank you. We'll sign off. Bye-bye.
Bye.
End the meeting?
Yes, please.
Thank you, Dr. J.K.Reddy, sir.